Well, good afternoon, everybody, and thank you for joining us. My name is John Lesinski. I'm a candidate for Congress in Virginia's 5th District, and I'm joined today by Dr. Hugh Hill.
Good evening.
We have a very interesting program for you over the next 45 to 60 minutes. Dr. Hill is a emergency physician at Johns Hopkins University. However, what I've also come to learn is that he is a lawyer by profession. So we have with us here tonight a doctor and a lawyer. And somewhere in there is a joke, but I'm not quite sure where it is, and I don't think we'll go there. Let me read your bio, Hugh, because I think it's impressive, and I think people need to know your background and understand what you bring to this program today.
Fine, embarrass me.
Hugh Hill, MD, JD, Assistant Professor of Emergency Medicine at Johns Hopkins University School of Medicine, and a health lawyer. Undergraduate degree from Washington and Lee University in Lexington, right, and medical training at VCU in Richmond. Your law degree is from UVA.
Virginia's been very, very good to me.
Very, very good. You have extensive experience serving in and managing emergency departments, including as the first civilian director of the Bethesda National Medical Center ED.
I don't think you visited us when you were a Marine.
I think I did, actually. Yeah. You served in government at the Armed Forces Institute of Pathology. At the Center for Medicare and Medicaid Services, you were responsible for the process determining what products and services Medicare covers, right, and later for fighting fraud, waste, and abuse.
That's right.
You're currently a board member for Ingleside Life Plan Community, and your wife, Sandy, is a dermatologist and a nationally recognized skin cancer expert, and a fellow resident of Rappahannock County.
And our 5th District.
In 5th District.
As it's currently construed.
Welcome. There are been a lot of town halls, been a lot of discussion, obviously a lot of focus and emphasis on COVID-19, coronavirus. And many of you that are here with us this evening have become subject matters of your own by just everything that's been available and out there. But I thought it would still be beneficial, Dr. Hill, if you could start out with explaining what exactly is COVID-19.
Well, I appreciate the opportunity to be with you tonight doing this and to try to add to hopefully some of the good information that's already out there. And thank you for the service that you do to our district by putting this on. Can you put up that slide that shows the picture of coronavirus? We have an electron microscopy picture of coronavirus, which immediately will show you why it's called coronavirus. Coronavirus is a family of viruses that cause the common cold. Obviously, this one's a little different and more than a little worse. But it has these particular outcroppings that look like a crown under an electron microscope, thus coronavirus. It's a novel virus. It's a new kind of RNA. That's the core replicating mechanism of the virus. It's wreaking havoc in large part because it's new and we don't have any immunity to it.
Well, how bad is it? I mean, how bad are we? I don't know if you compare that to the common cold or you compare that to the flu.
Well, I don't want to geek out and use too many numbers, John, but I think they're helpful. I'm going to refer you to the bring this back up. I'm going to refer you to the Johns Hopkins website. It's got a wonderful tracking map that the people in the School of Engineering Science put up, not the people in the School of Public Health, which allows you to see where it's occurring and what the numbers are updated almost continuously. And see, do you have those numbers, Dave? Can you bring that up?
I can find that, yeah.
Okay. So it shows the number of worldwide cases are over 190,000, with about 7,500 deaths, with the good news that over 80,000 people have already recovered. In the United States, we've had 5,700 cases, and we're almost at 100 deaths. So numbers-wise, it looks like we're doing better than China. But the problem is that the Chinese curve of incidents, the number of cases coming up,
Mm-hmm.
is because of their very strong measures of isolation, we think, possibly, are starting to go down. Now, of course, this is always subject to some concern about the reliability of the numbers. I think you'd understand the political charged nature of revealing information about a country's illness. And that had something to do, if you'll think back to the Spanish flu, with why it was said to be Spanish.
Right.
It may have even actually started in the United States.
Right.
But everybody called it the Spanish flu.
Well, and we've heard some people try to refer this to a particular part of the world where this broke out. It's caused some fear, and it's caused some a little bit of hysteria as far as Wuhan, Asian Americans,
right?
So
there are probably people that would like to call it the Chinese flu, I imagine.
Yeah.
I don't know that that's helpful right now.
No, I don't think it's helpful. No, it's not helpful at all. Talk a little bit about what's happening in Italy.
Oh, in Italy, it's a terrible crisis, and an enormous number of people have died. The death rate there is exceeding the flu by a huge multiple. Death rate in a bad flu season is about 0.1% of the cases. In Italy, it can be as high as 6%. Now, the reason I'm hedging on that is because we're just still in the early stages of this, and we don't have enough testing to be able to know whether that's the death rate of cases that have been identified or of people that have been infected. And that lack of testing is what's really hampering us, the United States. And Dave, don't worry about not being able to bring those slides up. I'm confident that we will be able to have those up later on your website.
Yeah, we're going to follow this up with information for those who weren't
right?
able to tune in or want to watch. They'll be able to pull these slides down. We can continue to make reference to it as we go through this. Are we making the same mistakes that Italy made here? Are there things that we are doing that may cause an outbreak in the United States of the proportions that we're seeing over in Europe?
Well, in terms of not responding quickly enough and aggressively enough initially, yes, we're at that risk. But one of the statistics that I came across today, in fact, that makes a small comfort for us is the fact that the Italian population is generally older than ours. And so we know that older people are much more susceptible and much more at risk of having bad disease. We don't know exactly why that is. We don't have a breakdown yet of old people with comorbid conditions and old people without. And maybe the numbers look bad for old people because they also have diabetes, COPD, other diseases that make them vulnerable. Or it might just be because they're old, or it might be some combination. But clearly that's a risk factor, and that's what's killing a lot of people in Italy.
So you had referenced earlier testing, which everybody knows is absolutely critical to getting our arms around how devastating this could potentially be.
And making predictions and planning, absolutely. And you're right. And I appreciate an elected official who understands the importance of that.
Well, what I understand is that we're very, very far behind, or we were not prepared with the amount of test kits that were certainly needed for something like this. And you've got your medical stethoscope on, but you've also got your law degree in hand here. And I know that you understand certain departments, certain facets of government. Was there a disconnect there with our federal government with respect to the CDC and the FDA and how this was and how it may have related to test kits and how they rolled out?
Yes, and it's coming home to roost now.
Yeah.
The head of the World Health Organization, rather pithily a couple of days ago, said, you can't fight a fire blindfolded. And basically, that's what we're trying to do without adequate tests. So, for example, if you look at the raw data of people who die, who have the infection, it can be as high as 3%. But when you do get some information, most of which is coming from China and South Korea right now, about the number of people who are infected who die, it drops to about 1.2%. And when you think about the way these things spread logarithmically.
Mhm.
One person infects 2 to 5, somebody else infects, it just grows and grows and grows.
Mhm.
You really need to be able to test dramatically.
So let's
Now,
contrast it.
do you want
I'm
to?
sorry.
I'm sorry.
Yeah.
Your question offered me the opportunity to, and we don't have to do it if you don't want to talk a little bit and to complain a little bit about why we got into the trouble we got into with not having tests ready.
Mhm. Mhm.
And I think that might be of interest. And I think it speaks to the role of the legislator, the
Mhm.
congressman or woman who is exercising oversight over federal agencies.
Mhm.
Uh,
There certainly seems to be more of a. There needs to be absolutely more of a streamline. There needs to be more. I think what we're suffering from right now is we don't have we have too many experts, which means we don't have an expert. You have to rely on the experts in the situation, and they need to be coordinating the response. They're clearly going to be having.
It's also bureaucratic methods.
Mhm.
I mean, you have experts at the FDA, you have experts at the CDC, and when I was working in HHS, we had experts there as well. And I know, having managed in the bureaucracy, the mindset of the bureaucrat is conservative and wants to avoid being blamed for something going wrong.
Mhm.
So we didn't prepare to be, we were not nimble, we weren't prepared to be nimble
Mhm.
when this hit.
Mhm.
The South Koreans, by contrast, having lost so many people to SARS,
Yeah.
to that previous viral epidemic that hit them so hard, they had already streamlined their approval process for both private industry and institutional laboratories
Mhm.
to be able to generate tests quickly. So when you look at the graph, one of the graphs we'll put up on your website if you'll
Mhm.
allow it after this,
Mhm.
it shows that in the United States, almost all of the tests that were done for 2 months were done at the CDC. And it's only been after the CDC and the FDA started to approve test kits being produced by private industry and by hospitals
Mhm.
that we started to see massive numbers of tests go up
So let's shift
into the range we need to be.
So let's shift to Johns Hopkins, where
Yes.
you're on the front line, you're on the cutting edge here. In fact, we appreciate you being with us here this afternoon because I know you have to be back in there tomorrow.
I'm looking forward to the next 3 days of working there. Yes,
You now have your hospital now has approval for its own test kit,
and we're doing our own tests there. They
Right.
don't have to be sent to the CDC or to the Department of Public Health in Maryland anymore.
Right.
Or if you were in a Virginia hospital, to the Virginia Department of Health.
So what is that? But that certainly puts rural hospitals certainly not necessarily at a disadvantage, but they don't have the capability, they don't have the infrastructure to be able to even get close to doing something like that. In our rural hospitals in the 5th district, maybe with the exception, well, UVA not being a rural hospital, we're going to be a lot more reliant on what you talked about, the streamlining of the bureaucracy and the federal government to be able to be prepared for an outbreak such as this. I understand that for the Ebola outbreak, the CDC came up with a 425-page lessons learned. And in the military, when I served and I had time in the Pentagon, we spent a lot of time on contingency plans, and then we spent a lot of time on lessons learned. We talked about not fighting the last conflict. We talked about fighting the next conflict. And it sounds like the CDC was on track for that at one point, with respect to Ebola. But doesn't seem like that lesson learned or that experience. I think with this administration, we threw a lot of that out.
Boy, I wish that attitude and that mindset that you exhibited when you were working for the military had been in place, overseeing the bureaucrats that could have seen this coming and should have seen this coming. We've had episodes after episodes of MERS and SARS and flu epidemics and H1N1 when we could see the beginnings of something like this. And truly, we should have been better prepared, and we should have thought about the bad things that could happen in terms of preparing the country.
So in your opinion, as a healthcare provider and what you're seeing and working with a large hospital, are we beginning to flatten the curve?
Not yet.
We talked about,
Not yet.
I think everybody knows the term flattening the curve, where, if you looked maybe at the Spanish flu in 1919, you looked at the city of Philadelphia, which was in great denial over what was happening. The curve was very steep. In St. Louis, contrast that, it was very shallow because they practiced separation. They understood that there were certain things, and they weren't in denial. Are we? What are we headed toward here? Are we headed for a steep curve?
We're into a very steep curve, rising rapidly.
Mm-hmm.
We do not know yet about the results of the intervening measures we want to take. But to start with, we shouldn't be doing stupid stuff. For example, DC Metro has decided that because of decreased ridership and costs, they're going to decrease the frequency of the trains and the number of cars. So that sounds on the surface not stupid. But what does that do to those cars? It means there's going to be more people packed into a smaller space than you would have otherwise. Now, maybe you still have to do that, but you at least ought to think about that.
Well, take that example and translate it over to the 5th District. Certainly, you may be able to talk about how that might relate to Charlottesville. But as we know, in our rural, in the 5th District, many of our communities, many of our counties are very rural. And I would think that would be a distinct advantage that we're separated or we're spread out more. Yet there are obvious things that have been told to us about keeping distance, whether it's self-quarantine or no gatherings greater than 10 people. Whether you're practicing, whether those are best practices in our rural communities or whether they're in the more urban areas, are these going to serve to flatten this curve? Is that what we need to be doing right now?
We hope so. And I'll cite you some data that just came out last night. This is Tuesday, the 17th. Some data came out Monday, the 16th, from the Imperial College in London, which has gotten everybody's attention and is actually a little dismaying. You're right that being spread out is an advantage. But you're also correct, I believe, that for rural hospitals, it's going to be tougher to get test results timely. Just imagine from the individual patient and physician and nurse perspective. Someone comes to one of our smaller hospitals in a rural area in our district, and they have the symptoms, and they have a fever, and they have a cough, and they have body aches, and they feel terrible, and they need to be tested.
Should I take that person to the emergency room?
You should call the doctor first.
Okay.
Or call the emergency room first. And let's say that person also has an exposure. Right? They were around somebody or in a group where they might have been exposed. You told me that we just have discovered that there's at least one person in Charlottesville who's tested positive. So if someone was around that person. So they come in, and you've got to do a flu test first, right? And if it's negative, then you do the coronavirus test, which means that those tests have to be shipped out and you wait for the results. And how long does that person have to be kept isolated?
One of the frustrations that we've had expressed to us, and we've been listening to our constituents here and our residents here in the 5th District, is they don't know where to go for testing. And I'm not sure there is a place that they can go.
At this point, they're left with the emergency room in almost all of these jurisdictions. We're setting up, working on some remote testing sites and some opportunities to test people where they won't be exposed to great crowds of people waiting in an emergency room waiting room, and trying to deal with that. But at this point, that's all we've got.
So the president
But the question of whether you should go in and be tested or not is something that you got to think about a little bit.
Yeah. And certainly when it comes to, and you mentioned this earlier, the elderly, who are the most vulnerable in this coronavirus crisis. There are some real heartbreaking stories out there about loved ones not being able to visit their families, their parents, their grandparents that are in assisted living centers or nursing homes. Is that just the way it has to be right now?
For now, yes.
Yeah.
You need to be an advocate for your loved one in those facilities. But you also need to not, you're going to have to do it remotely. You're going to have to talk on the phone. You're going to have to talk with the people that are taking care of them as often as you need to make sure that they're being well taken care of. And their needs are being met, because you've got to balance that against the risk you present by coming into those homes. One of the recommendations that's been toyed with recently is the suggestion that people over a certain age, and that varies depending on who's making the recommendations, should be alone starting now. should be staying at home just because of their age and vulnerability. It's not just their vulnerability. It is that when they get the disease, they get it worse and they spread it worse. There's also this concept of the inoculum, which is a geeky term I'll explain. You have to be exposed to enough virus particles to overwhelm your immune system to get the infection. That's part of why people that are vulnerable, because it takes less of an inoculum. But if somebody has just a little bit of the infection, they might spread a little bit of the virus. But if somebody's really sick and spreading an enormous amount every time they cough or sneeze, then that's going to put a lot of virus particles out there and expose a lot of people.
Are you expecting your hospital to become swamped? That's the term being used now.
We're making plans for what to do if that happens, as if it were going to happen.
Yeah.
Back to your question about bending the curve, and before we get to Q's and A's, I'd like to be able to talk about that a little bit, because that's such a great question, and I'm not surprised that you would think to ask that. The Imperial College data that I referenced used mathematical modeling of, admittedly, Chinese data to suggest what happens if we impose these measures. And you can see for the duration of the period on the graphs that the intervention is affected. The curve of the incidence, the frequency of severe cases per 100,000 population drops with each additive intervention, right? Do nothing and it's this kind of a spike, right? But then it drops down. But it's still, even if we do everything that's been proposed, draconian measures, severe isolation, we are still going to have enough cases that it's going to overwhelm the healthcare delivery system. And the other thing, they did a graph for the United States showing that if we impose all these measures, let's say July, we lift them, right? Because we got to get going again. We can't just hunker down forever. Almost immediately, the incidence starts to come up again. Am I off camera there? Let me do this over here. The incidence starts to come up again. And so that's got people's attention and is worrying people a great deal.
So how do you, given the president has said it might be July or August, he's no subject matter expert, but he's getting that from, what I hope for our reliable sources. How do you see this? What do you see happening in the next 2 weeks, 4 weeks, 4 months? Are we on the?
We're going to be on the upslope for 2 to 4 weeks. I don't see how we can avoid that. Even with a continued surge in testing.
And this will be the really bad.
It's because people have already been exposed. In the first wave of this viral epidemic, estimates are that between 40 to 70% of people are going to be infected. 70% of the population being infected. Now, I'll grant you that based on that nice enclosed study of the Princess Cruise Line ship, where there were 3,000 people on board and they were tested, and 600 of them tested positive, half of those people were asymptomatic. That tells you very clearly that most cases are going to be mild. But even if you take a small percentage of cases, if you've got a big denominator, you've got a big problem.
And I just have to tell a personal story. I was out, had picked something up this weekend from a business establishment that was doing quite well and had a lot of people there, enjoying themselves, mostly in their 20s and their 30s. I wouldn't have known any different having pulled up there. Talking to the business owner, he felt it was going to be a very different situation in a week. But if we don't get serious, if we don't, regard this as important and take ourselves out of that or self-quarantine, it's going to hurt our small businesses tremendously. But it's really what we have to do now, which is why I think the federal government does need to step in, not only to help those small businesses. We talk about bailouts and tax relief. A lot of the tax relief went to those firms and those people from the president's tax cut. That really isn't going to benefit the people that are going to be affected mostly by what we're dealing with right now.
From a public health perspective, you're absolutely right. Regardless of what you think about any ideological choices that have to be made about whether to pay people or find tax dollars to pay people to stay home. we need to get them to stay home. I suspect you know a lot about the 5th District and its people. And isn't it true that a lot of folks that work in our district really can't go without a paycheck? They're going to try to go to work even if it's not.
It's an insidious. The virus is cruel, especially in that it is hitting the most vulnerable, whether that is our elderly or whether that is the people working in the service industry. Or, I mean, we heard from a substitute school teacher this week who was sent home because the schools are closed. There's not going to be a paycheck for her. She's concerned about everything from how do I put food on the table to what's this going to do to my credit score? And food is another huge issue here. A lot of our children in schools get meals. Most vulnerable children take meals home with them on the weekend. There are communities that are rallying and coming together and making sure that happens. But, this virus is having downstream effects. Families are home. Childcare is expenses are up. They're needed. If the parent still has to go to work, that's why I think that anything the federal government can do in the way of relief doesn't necessarily, payroll tax isn't necessarily going to do it, because the people that are the most vulnerable probably aren't on the payroll right now. So if there's going to be any kind of bailout, for lack of a better way of saying it, because we've gotten used to that term, it needs to be for those that are the most vulnerable and that can reach down into our very communities.
It does, and even if you don't conceptualize it as a bailout, it needs to be done to incentivize, to motivate people to stay home, to make it possible for them to stay home, if that's what we need to do. Now, I've talked a lot about how dreadful this all is, and rather than go to questions with me sounding like a total alarmist, I'd like to offer you something that I think about to help me have some perspective on this. A bad flu season year, 66,000 people die in the U.S. Right?
66,000. Yeah.
And that's because there's so many cases, right? Even though you've got a mortality rate of 0.1%. When you think about this disease, my best guess, in my humble opinion, it's going to be like a 4 to 5 times that in terms of a bad flu season. It's not going to be the millions of deaths we saw in the Spanish flu.
Yeah.
In part because we're taking these measures. And I think the sky is not yet falling. This is not the big one. Right? We're fortunate that this is not the one that's going to really knock everything out, like the pandemics that we've been truly afraid of. However, I do recognize that there are tipping points. We cross 2 tipping points. And in a good flu season, in a bad flu season, our surge capacity is used up. The healthcare institutions, we're full of hospitals. We've got people waiting forever to get a bed if they need it.
Yeah. Right? Yeah. And the ICU beds are of a great shortage, especially, I think, for example, Fauquier Hospital has maybe 8 ICU beds. That's part of the infrastructure that these hospitals need, right?
And they won't be able to ship people
ICU
to another
beds,
hospital because
ventilators, right?
If they're terribly sick, and I hope we don't have to face terrible choices in that regard, but we may. And the other thing is that as the world economy crashes, the supply chains are going to hurt us badly. People don't realize we are in an interconnected world, and to the extent that we take a America first and other countries take a India first or China first position, the supply chains get cut off and we can't get desperately needed medical supplies. India has already done something just in the last couple of days to keep stuff that was being shipped out from leaving, because they're taking that we're going to take care of our own people first.
So the patient protective equipment that we get here in the United States primarily comes from overseas, correct?
The personal protective equipment, almost all of it comes from China. Yeah. Some of the masks do.
Yeah. So I would think, to your point, in supply chain, that would be concerning if we didn't keep this global flow open.
Yeah. And it becomes very important to have good international relations and not be bullying other countries at this point.
So we have talked for about 30 minutes, and I think it's probably only fair that we may open this up for any questions that we may be getting. I know we've got Dave in the studio here. You'll hear a voice from off screen. Dave, can you help us out with?
Sure can.
Thank you.
So Amanda has a question. Will the strain on ERs put other people at risk?
Yes, and yes. And on healthcare in general, if hospitals are full of sick coronavirus patients, other healthcare is not going to get delivered.
Yeah.
And just think about what happens to people who are vulnerable to the infection. They're not going to be able to get anywhere near a hospital. And there's some concerns that even situations in doctors' offices are going to start to be strained.
Well, medical staffing is a big issue here. We've been understaffed in our healthcare for years now. Just by way of example, what is Hopkins doing to try to keep people like you from safe and from contracting the virus so that they don't take you off the playing field?
We've got dormitories set up, so if I go to work tomorrow and they don't let me go home, they've got some place to put me up before they throw me back into the fray. You know, I'm so glad. I know that you've been involved with efforts in Rappahannock County to try to increase the workforce at the nursing aid level and the people we're training to do that sort of thing. Those folks are going to have to step up and do more than they have done in the past. And we're going to have to relax some of our hierarchical restrictions on what people can do.
Certainly, we have to focus more in the future on training, bringing more healthcare providers into, as our society ages. And that fact that you gave on Italy was not lost on me about how they're perhaps disproportionately elderly. Our demographic in the 5th district, especially in the rural areas, tends to be, certainly above average, above median. We've got this double-edged sword where our demand is going up and our supply for everything from first responders to, as you say, whether it's nurse practitioners, certified nurses, assistants, that pipeline is getting, skinnier and skinnier. So I think we as a country would need to look at how do we incentivize and how do we train more. Perhaps there's bureaucratic barriers there that keep us from not only attracting but producing the amount of people needed in healthcare, and also telemedicine. Telemedicine is going to be the future, really, a big part of the future for rural healthcare. You don't have telemedicine unless you have broadband access.
And I know that you've been talking about broadband for years in our area, John.
Well, and it's been an issue. It has been an issue for years, not only in the Commonwealth here, but nationally in our rural areas. We talk about it as the rural electrification issue of our time. And we all know now it's not just about being able to get your favorite Netflix shows. I mean, this is everything. And this is really bringing home the healthcare piece. But as we send our children home and close our schools, the spring break will burn off, and then schools will be looking at how are we going to do instruction. It'll be online learning, which will work very well in our urban areas, but in our rural areas, it won't work so well. Perhaps it's a wake-up call for that. Telework. We're telling everybody to stay home. A lot of companies are telling people to stay home now, work from home. That's going to be a blow to our economy, without a doubt. Especially with those who are sent home that don't have internet access or high-speed internet, aren't going to be able to telework.
Absolutely.
So there are some real downstream lessons here, not only related just to healthcare and virus, but and this coronavirus, but also infrastructure lessons as well. Dave, any?
Yeah, we have a question from Elin. What is one of the biggest or most important misconceptions or myths about COVID-19 you would like to correct?
Well, I certainly don't think it was a bioweapon created by China. That's been kind of a fun conspiracy theory that's floated around. I'd like to correct that.
There are those.
I think the the notion, people are this has been. I appreciate the question, but my sense of it is maybe it's just the people that I talk to. Folks are really on top of this, trying to learn about it and trying to understand it.
Mm-hmm.
And so maybe there are fewer misconceptions. That one is, I suppose, that this virus is not aerosolized. It's not like the flu in that it's like a less than 1 micron sized particle that floats around in the air for hours after somebody sneezes, like the flu or measles or something like that. It's droplets that are bigger, and gravity pulls them to Earth within about an hour, and that's why surfaces are more important for this than they are for other things. It's mostly airborne spread, but it's also on surfaces. So I think maybe one misconception is that we need to treat this like the flu insofar as aerosolization is concerned. No, it's droplets, so droplet precautions should help.
Okay, good.
I hope that's responsive, Elon.
Yeah.
Ted wants to know, and it's actually kind of tied into another question, so I'll combine them. Beyond staying home, what are the best ways for the U.S. to avoid getting into a situation like Italy is in right now? Like beyond, like more specifically than just staying home.
Separation.
Social separation. Setting up the ability to test people in settings where they won't have to come together in huge crowds. So remote testing sites with individual ability to have somebody come in, be tested, scrub it down.
What do you think of these drive-by testing areas that are being set up in New York?
The problem with drive-by testing is you drive by. You leave the testing site and you keep going. What I've advocated for, and we're talking about trying to figure out how to do at Hopkins, is to reach out to people in their homes. Ideally, you would call and you would say, I have these symptoms. I'm not sure about how bad it is. We would be able to come to you, make an assessment as to whether you needed to be tested, test you, and if you're not too bad off, stay there, but at least we would know whether or not you have the virus.
I should know this, but how quickly do you get results once you're tested?
Well, you can get a flu test back within an hour if you're at the site where it's done. But the COVID-19 test can take up to 3 hours. So this may sound silly, but the point of isolation is so important that at Hopkins, one of the things we're talking about, we haven't done it, is if people come to the emergency room and they do need to be tested, we may test them and say, thank you very much. Please go take this bottle of water and go back to your car. And we'll call you as soon as we've got the results.
Yeah, maybe the worst thing they could do is come in.
Well,
or be admitted. Or
we don't want to discourage people who need it from coming in.
Right.
But to be able to offer alternatives seems the better course.
So, my understanding is governors have a great power here. And in fact, whereas the federal government, as we talked before, can do a lot as far as the streamlining of the bureaucracy. If the CDC and the FDA are not speaking together, that's or coordinating or collaborating, that's causing issues. But really, the power of being able to close the schools, close the restaurants, set a curfew, that lies with the power. That power lies with the governor of a respective state.
Absolutely.
And I'm asking you now from your legal and your policy side.
So I'll change hats and say I've been asked by friends, why can't the government just sweepingly across the country close all this stuff down?
Yeah.
And
which is a reasonable question, and one that I would certainly.
It is by law, by statute, within the authority and purview of the governors and the departments of health of the states to do this. It's not when the president declares a state of emergency, there are certain things that he can do, but all of this restriction on movement and businesses and so forth has to come from the government.
Which is why you're seeing states like Ohio and New York and Michigan being more aggressive. Perhaps Virginia having a middle road, and other states saying business as usual. I don't think there's any more of those, but that's why you're seeing such a different patchwork, perhaps
right now. It doesn't matter so much, because until we know more, until we get those great volumes of test kits out there and use them, we don't really have the information to make informed decisions. But and so broad draconian measures seem worthy.
Yeah.
I think there's a quote from a former Secretary of Health about
it's
before an epidemic, everything seems excessive,
yeah,
and afterwards it all seems
it wasn't enough.
wasn't enough.
It wasn't
Yeah,
enough.
right.
Wasn't enough.
So I think as we start to come out of this and start to get more information,
Mm-hmm.
the locality decisions will seem more rational.
Mm-hmm.
Because Governor Northam could say, okay, in these counties we need to do this, and in those we need to do that.
Certainly seems to be more prevalent in the Hampton Roads area, in the Hampton Roads area, than it does necessarily in other parts of the state. Although, as you pointed out, we have now seen our first confirmed case in Charlottesville. Dave?
John, this question is for you. What concrete steps is your campaign taking to mitigate the virus and its spread?
Well, it's no longer business as usual, without any doubt. Everything in the way of fundraisers or meet and greets or meetings in communities that we had scheduled certainly are all off the table for a minimum of the next 30 days. And anything that we have in the pipeline is really a wait and see. We're doing our best to respect and practice our social distancing, and we're not going door to door, which is something that we would really like to be doing right now. And we're having to just adjust the way that we run the campaign, as are all the candidates, regardless of whether it's here in Virginia or elsewhere. This first effort here for this digital town hall is something that we'll look to repeat with other subject matter experts and others that we think can bring more information. These are the types of venues that we would have with a group of people in the room that we're just not going to be able to have any longer. But that doesn't mean, but we're just going to be practicing other ways of getting our message out and communicating, that is respectful of the safety precautions that are, that have now been that are changing every day. Frankly, I mean, today the governor said no groups greater than 10. I think yesterday that number might have been 50. So we're having to, we're having to adjust on the fly.
Timmy wants to know, I live with someone who is vulnerable. Should I get tested to ensure that I am not putting them at risk?
No. To start with, you can't get tested. We don't have enough test kits. To test the worried well and the simply exposed without symptoms would require a lot more tests. I hope eventually we will have enough to be able to do that sort of thing so that we can track and know more about exposure. You should be more vigilant because you're with somebody that's vulnerable about if you have symptoms yourself, and be more careful about social distancing than the average bear so that you'll be less likely to bring home the virus to them. But no, you shouldn't, and no, you can't. I'm sorry.
Okay.
Tough answer.
Yeah.
Craig says that he was confused by the administration's press conference yesterday. We were told 15 days to restrict our activities. Then we're told that July or August was a possible time horizon. Does that mean restaurants and gyms will likely be closed through August? 15 days at a time? I think he wants to know what the timeline is here and if there's any way to tell.
Well, part of this is just the confusion that's surrounded this from the top down, from the very beginning. Again, there was no, we've got a president that gets out there and gets out ahead of his skis and says things that, might be politically beneficial to him, whether it's for his reelection campaign or to appeal to his voters. When the truth of the matter is, and what anybody in a situation like this will advocate, or any government should advocate, is full transparency and open communication from a designated expert in an organization chart, that flows down through other experts from other departments. When we have press conferences that have 10 people up there, not practicing distancing, by the way, it sends a very mixed. It sends a very. They're all. Anthony Fauci gets up there and contradicts what other people have said, and so it sends very confusing messages as to whether or not. To your question, is it going to be 15 days and then 15 days and then 15 days? Some of this, in all fairness, I don't think, and I defer to Hugh, we don't know, but it certainly doesn't help that we sort of started out from a position of putting information out there that wasn't accurate, and then correcting it, and then putting out more inaccurate information. And then finally, yesterday, I think we got the first true answer, which is, this may be July or August before we really see this thing begin to burn itself out. Your thoughts on this?
One of the things I've always admired about you, John, is when you don't know, you say you don't know. And I think part of being transparent and reassuring the public is when we don't know, we say we don't know. Now, sometimes you have to make a guess, but you can label it as such. Mm-hmm. And while it is true that most cold viruses, the coronavirus family, mm-hmm. tend to recede during the hot months, mm-hmm. We don't know yet that this one will. It's mm-hmm. not an unreasonable hope that it will. Mm-hmm. But then it'll start back up in the fall. Mm-hmm. I have seen one research paper that's come out in the last couple of days that showed with 1 degree of temperature increase, 1 degree centigrade, not Fahrenheit, and a little bit of humidity increase, that the activity of the coronavirus, the one we're talking about, COVID-19, decreased. But right now, we do not know how long it's going to last, and we don't know about the results of these efforts we're making now that we talked about to bend the curve. So the better answer is to say, we don't know. Mm-hmm.
Yep.
Sorry.
We've gone about 45 minutes, so do you want to just do a couple more questions?
Yeah, we'll do a couple more.
Yeah. First of all, this seems pretty useful. Evans wants to know, how should we be cleaning surfaces?
Thoroughly.
How about that, Evans? Answer.
No, I don't mean to be flippant. And part of the challenge here is that, as you said, Hugh, this is droplets. This is gravity. This is this is on surfaces.
I have a substantive answer,
and I think this is probably your category more than mine, because I would say early and often.
I think this person is particularly concerned about when the public is involved in like your place of business. How should we clean surfaces to kind of make sure that people aren't at risk there?
Yeah. Well, you're not going to be able to make perfectly sure.
Sure.
But I was in a barber shop recently. I know it doesn't look like it, but I was, and they were cleaning down the seats, mm-hmm. swabbing them down with wipes between mm-hmm. each customer. And I know in my wife's office, they're careful about the chairs that patients sit in and in rooms to clean between patients. You should clean with something that's got a high percentage of alcohol in it. And if you don't have a cleaner like Lysol, which is labeled as, I'm not getting any endorsement money here, labeled for effectiveness against coronavirus, mm-hmm. just pure isopropyl alcohol. And the other thing that you can do is take your water that you're washing with and put a little bit of bleach in it. Don't add ammonia if you're using bleach, but just put a little bit of bleach in it and wash it down.
How effective is hand sanitizer? We've heard different things.
If it's got an adequate amount of alcohol in it, it's effective. Mm-hmm. But what it's not effective against is the next surface that you touch. And then if you go back and touch your face.
Yeah. And we're seeing a real shortage in these types of cleaning materials, whether they be the Clorox wipes or the hand sanitizers. I think everybody's very well aware that.
I think at this point, we believe that a good hand wash, 20 seconds, and let me demonstrate quickly, all the surfaces of the hand, mm-hmm. and like thus, and mm-hmm. the wrists. People don't mm-hmm. think about that. Mm-hmm. And getting between the fingers. Mm-hmm. 20 seconds of that with soapy water, hot if you can get it, and you're good.
Okay. And last question. Kathy says that she's concerned about rural hospitals. They seem especially vulnerable to getting overwhelmed.
Yeah.
What are your thoughts on that?
It's a very serious possibility and a very, very serious concern, specifically because of the lack of everything from ventilators to masks to ICU beds, and personnel and staff. It's probably going to be very easy for a rural hospital that has multiple cases in their community to become swamped or overwhelmed. I think as a community or even as a district, we're just going to have to find out how hospitals can assist each other or how first responders can assist other communities. I think one of the great things that we have going for us in this district, and certainly in the Commonwealth and in our country, is that I see people stepping up everywhere. I see people stepping up to help their neighbors when they know that they have elderly people in their neighborhood or in their community and they're not able to get to the grocery store or they're afraid to go there. When that word gets out, one of our staff members today heard about a specific situation where this became known out on social media, and that problem was solved because individuals who took personal responsibility and cared made sure that particular family got what they needed. We're going to probably have to take that up to a very high level when it comes to taking care of what our hospitals may need. Start out by, as you said, Dr. Hill, not necessarily your first instinct would be to go to the emergency room. It would be to call your physician. And if we can take those kind of steps and those kind of measures to take the personal responsibility of making sure that we're not putting our hospitals in a situation where they either become overwhelmed or perhaps become infected, that's something we can all do. We can all do as individuals, but there's no sugarcoating it. We have infrastructure issues in our rural hospitals.
So I have a final question. I hope we've got time for it.
Yeah, go for it.
What's the safest way to vote for you, John?
Well, that's going to be interesting because the primary is on June the 9th, right? And you saw Ohio cancel their primary today, while Arizona and Florida, went forward, and they advocated social distancing. There certainly is the possibility of early absentee voting and ways that you can cast your vote without necessarily going to the polls. I know the polls, a lot of them had hand sanitizer, and they were practicing. The people working them today in these other states had distancing criteria.
Mm-hmm.
So whether or not that's where we are on June the 9th has yet to be seen. But I encourage everybody to please put on their calendar that there is a primary vote, a Democratic primary vote on June the 9th in the 5th Congressional District, and that every vote counts and your vote matters. So I want to thank Dr. Hill. I want to thank Hugh for joining me, being with us here today. We hope you learned something, because that's the purpose of this, is to put forward information that you may be able to use. We are going to follow this up by putting sort of the high points or some of our talking points and the slides that you had presented on our social media platforms, so that you can come back and take a look at this. We're gonna wrap it up here shortly, because we know others have town halls. I think Congresswoman Wexton has one that's starting at 7:00, and Delegate Rome and Delegate Guzman are doing one jointly that also starts at 7:00. So if you have more of a thirst for knowledge and time on your hands, which I think a lot of us have more.
Or if you want a second opinion.
Or if you want a second opinion, yes. We encourage you to visit those sites. So again, thank you, and thank you all for joining us.
Thank you very much.